not sure where the chair people are, but I'm here and you're here, and it's 2 o'clock, so why not start? So we'll begin, okay? I hope the next speaker is here. But the title of the talk is New Tools for Fetal Echo 4D Ultrasound. First concept we're going to discuss is basic imaging principles of three-dimensional ultrasonography. Now, as you are aware, there are 3D and we talk about 4D. So first we're going to discuss the principles of 3D ultrasound and then go into the 4D or the stick acquisition. When we perform a 3D ultrasound, what occurs is, first, if you're scanning, for example, a fetus with two-dimensional ultrasound, you have a plane, you place the transducer, and you have an image. And you can move that image back and forth freehand, like we would see here, for example. With this 3D volume scan, the same principle applies, except it's done mechanically, where when you push the button, the scan moves through a certain area, it collects thousands of images, and then puts those images together to create a volume. Here's an example of that. It's doing the sweep, and then it displays the volume on the screen. And you can see that you have 3 planes that are displayed from the volume, and you can manipulate the volume any way you'd like. So that's using a mechanical array 3D transducer. The 3D display, it's important to understand what you're observing on the screen. I've color-coded this so you can see more easily what the images represent. This is the acquired plane called the X plane, and then the Y plane is perpendicular, as you see here, to the X plane. The Z plane is perpendicular, running at this angle to the X plane, so it forms 3 planes, all perpendicular to each other. For the most part, we examine the X and the Y planes for most of our work because this image has the highest resolution, followed by this image which has less resolution, followed by this image that has the worst resolution, just because the way the images are constructed. Now here's an example. When you do a 3D static sweep that I've just described, if, for example, you sweep too slow, then you will see artifact representing cardiac cycles. So when you understand how to approach this, what we try to do is find the fastest sweep speed with the highest resolution. So if you have real high resolution, the sweep speed is slower, and you may find this artifact to be present. If the sweep speed is really fast, you will not have the artifact, but the resolution will be decreased. So we find a happy medium between the two. The fastest sweep speed, the best resolution. But this shows the artifact that you see with a 3D acquisition. Now here we see, for example, we have a lower resolution, and what has happened because the sweep speed is faster, you do not see the artifact of the cardiac cycle in this plane. So let's go back and compare. Higher resolution, but artifact because the sweep speed was too slow. Lower resolution, but no artifact because the sweep speed was faster. So this is what we trade off when we do a 3D static sweep. Now let's look at 4-dimensional ultrasound, the principal images underlying this. With this concept, again with a 2D display, we're simply moving the transducer through the field freehand, as we see here. With a 3D volume scan, it does the same thing, except it does it in a much slower speed, acquiring thousands of images, and it creates them, stacks them one behind the other, creating a volume. Now these are the important principles when we collect a stick acquisition. There are several settings. First we have the second setting, SECONDS, seconds. So 7.5 seconds, 15 seconds. Let me just illustrate what happens. If we have a collection of 7.5 seconds over 40 degrees, one has the corresponding images that are collected from the stick acquisition. If you increase the time over the same 40-degree angle to 15 seconds, you have more information collected by the system. That is a higher resolution image. If you want to have the highest resolution image, you'd have the longest time period for the acquisition and a smaller sweep angle. So by adjusting the time of acquisition and the angle of the sweep, you can maximize the resolution of the stick volume. So these are the two parameters we adjust: the seconds, the time it takes to do the sweep, and the degrees in which the sweep goes through. So we make the sweep angle as narrow as possible to fit the anatomy that we're examining. Here's an example of a stick display. We have the 4-chamber view here, and I've outlined just for representation the interventricular septum. Here's the en-face view. Remember, this plane is perpendicular to this plane right here. Here's a corresponding color image of the same acquisition. We see the shunting VSD here, and here we see the location of the VSD in the entire septum. So again, this provides us two planes that are perpendicular to each other. Here's just a clip of that sequence. Okay, now, the stick also is subject to artifact. And let me show you, for example, here's a 4-chamber view, and this is the short axis view, and we see there's no artifact in this plane because the fetus was still, it was not moving, the mother was not breathing. She was breathing, but we had her hold her breath. Okay, and here's an example of that. So we see almost a perfect acquisition in the B plane and the corresponding 4-chamber view, and as I move this cursor through the field, we can see the various images that appear in the B plane as we're going back and forth. So this is a good stick acquisition with no artifact. You see we can rotate the image and see various aspects of the heart. Here we are looking at the septum. Here's the septum en face. So it gives us a lot of information and a lot of chance to manipulate the image and look at a number of different cardiac structures. This is a good stick acquisition. Now, this acquisition has artifact because of fetal breathing or maternal breathing, and so we see the interruptions right here, and therefore this image now becomes less easy to interpret because of the artifact from movement. So as mentioned earlier in one of the other sessions, one of the difficulties with stick is maternal breathing or fetal movement. If we don't have those, then we have a very nice image data set to examine. Another application of the stick data set is we can draw a line and create an M mode, an instantaneous M mode on the screen on the right, as you can see. This is very useful for looking at certain aspects of the anatomy and also for making measurements and looking at timing relationships. So this is a new feature that's available now on many of the systems that have the stick ability. And you can see by moving the line, I can see lots of different aspects on the M mode over here on the right. Okay, let's do this now. Now, we can also take and do a real-time 4D image, but again, with real-time, you see the structures, but again, they are less clear because of the slow sweep speed of the transducer. Now, let's now go to the matrix array, and if you were here on Friday, you know that this was mentioned and discussed. The matrix array is a special probe that acquires all the information simultaneously. And you can have perpendicular planes like we see here. Here's the 4-chamber view. Here's the ductal arch. Here's the 4-chamber view in the main pulmonary artery, and the 5-chamber view and the 4-chamber view. So we have the ability to simultaneously see, without any type of artifact, the views of the heart. This now is available for obstetrical uses. The company that makes this has just released a probe for OB work. Let's now discuss rendering, 3 and 4D rendering of cardiac anatomy. There's a number of different ways we can render the image. Let's look at some examples. This is a matrix array render. You can see, for example, in this, there's the ventricular septal defect right here. And here we have an AV canal defect right here. So you get a sense of seeing the heart in real time, but in a 3-dimensional presentation of a beating heart, that there's no artifact as we move the image through the screen. Again, this is going to be the future of fetal 3D, of fetal 4D imaging in the next several years. Now, this is what's called an invert mode. This is from a stick acquisition. And what we've simply done is taken the sweep, the 3D static sweep from this is the image that you would see, and we hit a button and we see the rendered image, and it looks very similar to this diagram on the right. It's a three-dimensional reconstruction. This is the main pulmonary artery, the aorta going behind it like so, the right and left ventricles. Here we see other examples of the invert mode rendering. We can also create a clip. This is a clip of that inverted image, and you can again see a three-dimensional structure of the heart and the outflow tracts, all acquired from a stick acquisition. Here we see another invert mode image, and here we have a number of structures. We have the diaphragm, we see the gallbladder, the stomach, these are the ventricles, the main pulmonary artery, the aortic arch behind it going down the back. So we can see a lot of structures that can be very useful when we're looking for pathology. Here's another example of the same thing, again, a bigger clip of the invert mode. So that's one way to take a look at the heart in a 3D live image. Here's an example of what? What would this represent? You have a transposition of the great vessels. Remember the transposition, the vessels exit the heart in a parallel fashion. You can see this very nicely on this particular clip. Again, done with the invert mode. Now this is another aspect of stick, but it's not using real-time ultrasound, it's using B-flow. And B-flow is simply, let's see if I can do this here, B-flow is recording the blood flow from the B-mode image. This is not Doppler. It's simply the way the system processes the information, identifies the blood flow in the B-mode component, and then we can reconstruct and create this four-dimensional image that we see here. And this is from a 17-week fetus, and it's very, very informative and very striking as we look at this anatomy. And here we see the next image shows you the various parts. Here we have the right and left ventricles. Here we have the main pulmonary artery, the right pulmonary artery going underneath the aorta, the ductus arteriosus, and this is during systole and diastole. It's a very elegant way of looking at the fetal heart. We also can create a three-dimensional image using the power Doppler or the color Doppler. Here we see again a rendered image from our stick and our static acquisitions of the vascular tree involving the cardiac structures. We also can render the heart, and we're looking now, we have a depth, we see a depth in this image. Here we have the inferior vena cava coming into the right atrium, the pulmonary veins coming in, the left and right ventricles. Again, this is from a stick acquisition. So there's a number of different ways we can look at the heart once we've acquired the stick volume. Now, this is the next thing I'm going to do is this is what I would say, this is the wake up part, okay? If you're sleeping, wake up. If you're not sleeping, that's okay, stay awake. This is how we use this technology to screen for congenital heart disease. There are several approaches. I'm going to show you three approaches, then I'm going to show you some cases as we work through the rest of this presentation. This is the automated multiplanar imaging developed by Dr. Alfred Abu-Hamid. And he has a static volume. They find a reference four-chamber view, and once they've lined it up using a specific protocol, by pushing buttons, the image rotates and displays the various views on the screen that contains the cardiac anatomy that we like to see in screening for congenital heart disease. Another approach is what's called the spin technique, which we developed. And the spin technique, basically what we do is we find the five-chamber view, we place the dot right here, and we spin it around 90 degrees, and we then see the outflow tracts open up. So this is a freehand, easy method to take and use. Here's an example of the spin technique. We're going to place the dot right here, just above the aortic valve. We're going to spin along this axis and watch what happens. Here we see now the aortic arch appear. We're going to place the dot in the pulmonary artery, and we see over here the bifurcation of the pulmonary artery, the three-vessel view. So simply by placing the dot in two places and spinning it, you see a lot of information that you need to acquire to examine the heart. Okay, the last area that we're going to spend a few moments on is tomographic ultrasound imaging. And what we do here is we're going to slice the volume in multiple slices. Why is this important? because this is a schematic showing you the views you want to see when you screen for congenital heart disease. We have the 4-chamber view, the 5-chamber view, the 3-vessel view, and the tracheal view. We've discussed this on Friday in other sessions. And that's simply acquired by placing the transducer in the chest and moving upwards towards the neck to display these views. You can do that freehand, or we can do it with TUI from a stick acquisition. Now look at this. This is a stick acquisition. We have all the views that we need. We have that are being displayed on the screen for the views that we want to see. And here we can see, for example, the 4-chamber view. We have part of the 5-chamber view, the 3-vessel view, and the tracheal view, all displayed on the screen as we're looking at this image. So we simply acquire the volume, push 2 buttons, and there we have the images, all displayed one next to the other. This is the easiest way, I think, to take and see this type of anatomy. Now, we're going to have some fun. We're going to look at some pathology. So wake up at this part. See if you can guess what's wrong. I'm going to tell you at the end, so don't feel bad. I'm going to show you the picture. I want you to look at it in your mind, say what's wrong with these pictures. Then we'll have push a button, and we'll have an overlay of labels, and then we'll have the answer. Okay? So here we go. What's wrong with this picture? There are 8 images. So look at it carefully. Now keep the answers to yourself. You don't want to make your neighbor feel dumb, okay? So just look at it. Now here's what we have. See, we have the ventricular septal defect, like you said, and the atrial septal defect right here. This is an endocardial cushion defect associated with a high risk for Down syndrome. Okay, and what's interesting about this, look at this view here. It looks like a normal 4-chamber view, doesn't it? And just a little bit lower than that is the defect observed. So you can see how people can be fooled. They look at the 4-chamber view and they think, this looks okay. But in reality, we have this pathology. Okay, next case. Case of pulmonary stenosis. Now, what do we observe in this case? We have several features that are important to observe. First, we see that there's tricuspid regurgitation in the right atrium. That suggests a high resistance to blood flow from someplace. Here we have at the level of the pulmonary valve in the 3-vessel view, we see increased flow, aliasing. And here we have some pulmonary artery regurgitation. So this is a case of pulmonary stenosis with regurgitation, tricuspid regurgitation, a dilated right ventricle. Okay, the next case. You can't see anything wrong with this because it's a large woman who's very large and a lot of adipose tissue and very difficult to image. And here we have the structures I've labeled, but again, not very clear until you turn the color on and you see the shunting VSD right here. See that? And right here. Let's go back. Do you see the VSD here? No, you don't. You turn it here, and there it is. So what does it tell you? Use color Doppler when you examine the heart, okay? The next image. Again, these are a sequence of images, and what you observe here is you see, of course, transposition. Here we have 2 parallel vessels. This is the mitral valve, left ventricle. The tube that comes out of this comes out and it bifurcates right here, like so. That's the pulmonary artery. And this is the aorta coming off the right ventricle. So this is, again, a case of transposition. Okay, another case. This is a case that it was the same case of transposition. And we turned the color on, and what did we observe? We saw a shunting VSD located right about here that we didn't perceive on the 2D image of this case with transposition. So again, the color Doppler helped us to see that. Well, this is a fun case. This is a case, again, you notice this is a large, well, you can't tell, but it's a large patient. She's not from Asia. She's not thin. She's from America and has had too many McDonald's hamburgers. And so we have lots of difficult imaging, but we see some structures here, and they look a little bit different. They don't look like they're supposed to. We turn our color on, or our labels, and we see that we've identified what we think is a VSD, and we have the chambers identified. And we turn our color on, and we also see some other structures that don't look right. But in putting this together, what we had to do was use the B-flow. And this is a case of truncus arteriosus, where we have the main vessel coming off the heart, one vessel, and the pulmonary artery coming off the side, the aorta coming off the top. So the B-flow helped us to identify the complex anatomy in this particular case at 17 weeks. Here's an example. It's called a right-sided aortic arch. And what happens here, we have the various vessels that or the images that we've collected. What occurs in the tracheal view, we have the ductus arteriosus, like so. The aorta should come down and join it like this, with the trachea to the right. But what happens with the right-sided aortic arch is the aorta goes around the right side of the trachea. Okay? And so this is the B-flow of that same defect in the second trimester fetus. Here's where the trachea is, and the aorta goes around that trachea. The ductus arteriosus goes this way. This is a right-sided aortic arch. This can be associated with a higher risk for DeGeorge syndrome, and it's easy to see when you look at the tracheal view and look at the pathology. Another example of detransposition. Here we have what we should observe. This is again a rendered image, the corresponding transposition like so. So in conclusion, what I wanted to do was to show you, because we only had 30 minutes, briefly discuss how, the differences between 3 and 4D ultrasound, some examples of how we would use this clinically. Let me close and just make these comments. 3D, 4D ultrasound is not used in a screening arena where you're scanning patient after patient after patient after patient. That's not where it's useful. It's useful when you have pathology. You're trying to then sort out what you found that's wrong on your screening examination. Then you bring in all the tools of the 3D and the 4D technology to dissect the anatomy, to see exactly what's wrong with it. Because that's where it really plays a role. Now, you could use it for screening, I guess, with the TUI approach. Some people have done that, but in our practice, we use it when we have pathology. And that's the real advantage. But but they have so many tools that you can use, it's important to understand how to use the tools, so when the time comes that you have to use them, you know how to use them. Okay? So what I would suggest, if you happen to have a machine that has this on it, learn how to use it. Even on normal fetuses. Learn how to use it, so when the time comes, when you have an issue, you know what tools to use to build your house, so to speak, or to fix your car. You know how to do that. Same tools for looking at the heart. Thank you very much.